as ophthalmologists, you're always looking for those subtle signs,
Absolutely.
trying to figure out what's really going on with your patients.
Yeah.
And I think today we're really diving deep into something that's super relevant to your practice.
Oh, for sure.
It's those neural tumors that affect the optic pathway, the
Yeah.
ones that really make you think.
Yeah.
So we're going to be talking about optic nerve glioma,
Okay.
optic nerve sheath, meningioma,
Uh-huh.
plexiform neurofibroma, and isolated neurofibroma.
Sounds good.
Really, those cases that can be tricky to diagnose and manage.
Yeah, these are the ones that, as ophthalmologists, you're often the first ones to see these patients.
Exactly.
You're the ones doing those detailed exams, finding those really early clues.
Right.
So this deep dive is really for you.
Yeah.
We're going to try to sharpen your understanding and inform your decision-making
Exactly.
for these complex conditions.
We've gone through all the latest research, and we're going to break it down.
Right,
We're
yeah.
going to give you the key clinical insights, the diagnostic clues to look out for, and the most up-to-date treatment considerations.
Okay.
We really want to make this practical and relevant to your daily practice.
Yeah, make it useful.
So let's jump right in and start with optic nerve glioma.
Okay.
Now, this one, it's primarily a childhood tumor,
Right.
typically diagnosed around 6.5 years old.
Okay.
But here's the thing, it's really unpredictable.
What way?
I mean, some of these gliomas are really slow growing.
Okay.
They're almost indolent. They just kind of sit there.
Right.
And then you have others that are much more aggressive,
Uh-huh.
and they can even spread to the brain,
Yeah.
which obviously is a huge concern.
Yeah, that's a big deal.
So that's what makes it so difficult.
It really does. Yeah.
You have to really individualize the management for each patient.
Absolutely.
And one of the first things to think about is neurofibromatosis type 1 or NF1,
Okay.
because about 30% of kids with optic nerve gliomas also have NF1.
Right.
And interestingly, those cases tend to have a better prognosis.
That's good to know.
Yeah. And then there's a much rarer type of optic nerve glioma called malignant glioma.
Mm-hmm.
Basically, it's glioblastoma.
Okay.
And unfortunately, that one has a really poor outlook.
Right.
And it usually affects adult males.
So when you're seeing these patients,
Yeah.
what are some of the initial things you're looking for?
Well, the classic presentation is gradual vision loss.
Yeah.
So the child's vision slowly gets worse over time.
Right.
And then that's often followed by proptosis.
Okay, so the eye starts to bulge forward.
Exactly. But sometimes the proptosis actually comes first.
Oh, interesting. So it's not always the same order?
Right, it can vary.
Oh, okay.
And in some cases, kids might actually present with sudden vision loss.
And what causes that?
That's usually due to bleeding within the tumor.
Okay, so that's an emergency situation.
Absolutely, you want to catch that early.
Right.
Now, when you're doing your exam,
Mm-hmm.
there are a few specific signs to look out for.
Like what?
So the proptosis itself is usually non-axial,
Non-axial.
meaning the eye isn't just pushed straight forward.
Oh, okay.
It's often displaced a little to the side, either temporally or inferiorly.
I see.
You might also see swelling of the optic nerve head,
Okay.
but over time that often progresses to optic atrophy.
Right.
And then you might occasionally see these little tiny blood vessels on the optic disc.
What are those called?
They're called opticociliary collaterals,
Okay.
and they basically develop as a way for blood to bypass the compressed optic nerve.
Interesting. So it's like a detour for the blood flow?
Exactly. And you might also see other things in the fundus like a central retinal vein occlusion.
Uh-huh.
But the really important thing is to look for any signs that the tumor might be spreading,
Okay.
especially towards the optic chiasm and the hypothalamus.
Right, because that could lead to neurological problems.
Exactly.
So if you're suspecting optic nerve glioma, what's the next step?
Well, MRI is really the gold standard for imaging.
Okay.
It gives you a really clear picture of the tumor,
Uh-huh.
and it shows you if it's spread beyond the optic nerve.
Right.
In fact, there's a really good image in one of our sources that shows the typical appearance.
What does it look like?
It's this kind of sausage-shaped swelling along the optic nerve.
Okay.
They call it fusiform enlargement.
I see.
CT scans can also be helpful.
Okay.
And the findings can actually vary depending on whether the patient has NF1 or not.
How so?
Well, in NF1 patients, you often see this smooth fusiform enlargement with really clear margins.
Okay.
And that's because the dural sheath around the nerve is still intact.
I see.
But in patients without NF1, the nerve can look more irregular.
Uh-huh.
And you might see areas of low density within the tumor.
Okay, so the imaging can give you some clues about the underlying pathology.
Exactly.
So once you have the diagnosis, what are the treatment options?
Well, that's where things get really tricky.
Right.
Because the tumor is actually within the optic nerve itself.
Uh-huh.
So if you do surgery to remove it, you're almost always going to cause permanent vision loss.
Oh, wow. That's a tough decision.
It really is.
So what do you do?
Well, in some cases, observation is the best approach.
Okay. When would you do that?
So if it's a pilocytic astrocytoma, which is the most common type,
Okay.
and it looks like it's confined to the orbit on the MRI,
Right.
and the child still has good vision,
Mm-hmm.
and there's not a lot of cosmetic disfigurement,
Okay.
then we might just watch it closely
And how do you monitor it?
with regular MRIs.
Okay, so you're looking for any signs of growth.
Exactly. And it's
Yeah.
worth noting that in some really rare cases, these tumors can actually regress on their own.
Really?
Yeah, it doesn't happen often,
Uh-huh.
but it seems to be more likely in kids with NF1.
Interesting.
Now, if the tumor's growing
Okay.
or if it's causing significant problems,
Right.
then we might need to do surgery.
Okay.
And the goal is to remove as much of the tumor as possible
Uh-huh.
while trying to save the eye if we can.
Right.
And the main reason we do surgery is to stop the tumor from reaching the optic chiasm.
Okay, because if it gets there, it could affect the other eye. And sometimes you might even need to go through the skull to get to it.
Yes, sometimes we need an intracranial approach.
Wow. That's pretty major surgery.
It is?
So what about those cases where you can't remove the whole tumor?
Well, if it's spread too far for surgery,
Mm-hmm.
then we might consider radiation and chemotherapy.
Okay.
Now, let's switch gears a little bit and talk about optic nerve sheath meningioma.
Okay, so this is a different type of tumor.
These are benign tumors,
Okay.
which means they're not cancerous,
Right.
and they come from the cells that surround the optic nerve called the meningothelial cells.
Uh-huh.
And they're more common in middle-aged women.
Okay.
Now, it's important to remember the primary optic nerve sheath meningiomas
Okay.
are actually less common than gliomas.
Oh, interesting.
Yeah, and about 2/3 of the meningiomas that affect the optic nerve
Right.
are actually extensions from intracranial meningiomas.
So they're coming from somewhere else.
Exactly.
Okay, and I know there are different types of optic nerve sheath meningiomas.
Yeah, there are two main subtypes.
What are they?
They're called meningothelial and samatasis.
Okay, and do those behave differently?
Well, they can have slightly different appearances under the microscope,
Uh-huh.
but in general, the long-term prognosis for adults with these tumors is good,
That's good.
but they can be more aggressive in kids.
Oh, really?
Yeah, about 25% of cases in children.
Okay.
And there's also a link with neurofibromatosis type 2 or NF2.
Right.
Now, here's a really helpful tip from the research.
Okay.
In optic nerve sheath meningioma,
Hmm.
the vision loss usually comes before the proptosis.
Okay, so that's the opposite of what we saw with glioma.
Exactly. So that can help you differentiate the two.
Right.
So what are some of the symptoms that patients with optic nerve sheath meningioma might experience?
Well, the most common one is gradual vision loss in one eye,
Okay.
just like with glioma.
Uh-huh.
But they might also have these episodes where their vision dims or blurs for a short time.
What do you call those?
They're called transient obscurations of vision. So it's like their vision is flickering.
Right.
And on exam, you might see the classic Hoyt-Spencer triad.
Oh, yeah, I've heard of that.
But it's actually not that common to see all three signs together.
Really?
Yeah. So what you usually see is optic nerve dysfunction,
Okay.
which can cause the optic disc to swell.
Uh-huh.
And then over time, that progresses to optic atrophy.
Right?
And then you might see those optic ociliary collaterals again,
Okay.
but only in about 30% of cases.
Mm-hmm.
And sometimes they actually go away as the atrophy gets worse.
Interesting.
And you might also see some problems with eye movement, especially upward gaze.
Okay.
And then eventually the eye might start to bulge forward.
So the proptosis comes last.
Yeah, usually.
Okay, so that's a pretty distinctive pattern.
It is.
What about imaging for optic nerve sheath meningioma?
Well, CT scans can show you some thickening of the optic nerve.
Okay.
And sometimes you can even see calcification.
Mm-hmm.
But MRI is really the best imaging modality.
Okay.
It gives you a much clearer picture of the tumor. And ultrasound can also be helpful, especially if you use a coronal view.
Interesting.
So you have different imaging options depending on what you're looking for.
Exactly.
Now, how do you treat optic nerve sheath meningioma?
Well, because these tumors tend to be slow growing,
Right.
we often just watch them closely,
Okay.
especially if they're not causing any symptoms.
So observation is the first line of treatment.
Exactly. But if the tumor starts to grow quickly,
Okay.
or if it's affecting the patient's vision,
Right.
then we might need to do surgery.
Okay.
But it's important to know that surgery to remove these tumors can be very difficult.
Why is that?
Well, they can really wrap around the optic nerve.
Uh-huh.
So it's hard to remove them completely without damaging the nerve.
So vision loss is a risk.
It is.
Yeah.
And sometimes if surgery isn't a good option,
Oh.
or if we need to do something after surgery to kill any remaining tumor cells,
Right.
we can use radiation.
Okay. Oh.
And there's a special type of radiation called stereotactic radiotherapy.
What?
Well, it's a very precise way of delivering radiation.
Okay.
So it targets the tumor very specifically,
Uh-huh.
and it minimizes damage to the surrounding tissues.
So that helps to preserve vision.
Exactly.
Okay, so we've talked about glioma and meningioma.
Right.
What about plexiform neurofibroma?
So this one is really interesting.
In what way?
Well, it's the most common type of peripheral nerve tumor in the orbit,
Okay.
but it almost exclusively happens in people with NF1.
Right. So that connection is really important.
It is, and it usually shows up in early childhood,
Okay.
often with swelling around the eye,
Uh-huh.
and it can actually cause the eyelid to droop in a really characteristic way.
How so?
Well, the eyelid takes on this S-shaped curve.
Oh, wow. That's pretty unique.
Yeah, it's very distinctive.
And can it affect other parts of the eye socket?
Yeah, it can actually involve the whole orbit.
Okay.
And sometimes it causes so much overgrowth that it really distorts the area around the eye.
Wow. So it can be pretty disfiguring. Now, I've heard that these tumors can feel pretty strange.
Oh, yeah, they do.
Yeah.
What do they feel like?
The research describes them as feeling like a bag of worms.
Oh, wow, that's a very vivid description.
Yeah, it's pretty accurate. So, are there any concerns about these tumors becoming cancerous?
There is a risk of malignant transformation.
Okay, so we need to watch out for that.
Yeah, and if you see any rapid changes in the tumor,
Mm-hmm.
that could be a sign that it's turning malignant.
So what do you do then?
Well, we might need to do a biopsy
Okay,
to check if it's cancerous.
right.
And the other thing to keep in mind is that radiation might actually increase the risk of malignant transformation.
Really?
Yeah, so we have to be very careful about using radiation in these cases.
Okay, so the treatment can be tricky.
It is. It's often very challenging.
And why is that?
Well, these tumors tend to grow into the surrounding tissues,
Uh-huh.
so it's very hard to remove them completely.
Right.
And because they're so close to important structures,
Okay.
any surgery in the orbit has to be done very carefully.
Yeah, you don't want to damage anything important.
Exactly.
Okay, so that's plexiform neurofibroma.
Right.
What about isolated neurofibroma?
So these are less common than the plexiform type.
Okay.
And only about 10% of people with these tumors have NF1.
Uh-huh.
And they usually show up later in life,
Okay.
typically in the 30s or 40s.
And what are the symptoms like?
Well, they usually have a gradual onset of proptosis,
Okay.
but it's often mildly painful.
Interesting.
And unlike plexiform neurofibromas, they don't usually cause vision loss
Okay.
or problems with eye movement.
And what about treatment?
The good news is that surgery for isolated neurofibromas is usually pretty straightforward
Really? Why is that?
because these tumors are well-defined
Okay.
and they're not as vascular,
Oh.
meaning they don't have a lot of blood vessels,
Uh-huh.
so they're easier to remove.
Okay, so that's a much better prognosis.
It is.
So as we wrap up this deep dive, what are the key takeaways for ophthalmologists?
Well, I think the most important thing is to always consider the patient's age,
Okay.
because that can really help you narrow down the possibilities.
Right.
And you also want to think about any associated conditions like NF1 or NF2,
Uh-huh.
and then pay close attention to the order of the symptoms.
Like whether the vision loss comes before the proptosis?
Exactly.
Or vice versa?
Right. And of course, you need to be familiar with the imaging findings
Absolutely.
so you can make the right diagnosis.
And then the treatment really depends on the specific tumor.
Yeah, there's no one-size-fits-all approach.
Right.
You really have to individualize the treatment plan.
Exactly. And I think the biggest takeaway for me is that these are complex conditions,
They are.
and they require a really thorough understanding of both the patient and the tumor.
Absolutely.
And as ophthalmologists, you're in a unique position to make a real difference.
Yeah, we're often the first line of defense.
You are so... Keep those eyes peeled for any subtle signs.
Absolutely.
And use all the tools at your disposal to make the best decisions for your patients.
Couldn't have said it better myself.
So as you go back to your practice, I want you to think about something.
Okay.
We've talked about all these different tumors.
Right.
Some are slow growing, some are more aggressive.
Nah.
But what if we could predict how a tumor is going to behave
Yeah, that would be amazing.
based on its molecular makeup?
Right.
So imagine if we could analyze the genes of a tumor
Uh-huh.
and use that information to determine the best treatment.
Right.
Maybe we could even develop targeted therapies.
Wow.
That would be a game changer.
It would, and that's where the future of this field is heading.
Exactly.
So it's an exciting time to be an ophthalmologist.
It really is.
We're learning more and more every day.
Absolutely. And that knowledge is going to translate into better outcomes for our patients.
I completely agree.
So keep learning, keep exploring, and keep pushing the boundaries of what's possible.
That's what it's all about.
It is.
Thanks for joining us for this deep dive.
My pleasure.
Until next time, take care.
Bye.